Causes of embolus formation. The vast majority of emboli derive from the dislodged thrombus, and we call them thromboembolism. Less commonly, emboli are composed of fat droplets or bubbles of air or even nitrogen, sometimes atherosclerotic debris, which we call the cholesterol emboli, tumor fragments, bone marrow fragments, or even amniotic fluid, and we will touch base on those in a minute. The consequences and complications of embolus formation depend on its site of origin. As you know, there are two types of circulation: pulmonary circulation and systemic circulation. Let's remind you with both. Pulmonary circulation, as you may recall, transports the oxygenated blood from the body to the lungs to absorb oxygen and release the carbon dioxide. The oxygenated blood then flows back to the heart. Systemic circulation moves the blood between the heart and the rest of the body. So it sends the oxygenated blood out to the cells and returns the deoxygenated blood to the heart. So the primary consequence of systemic embolization is ischemic necrosis due to the oxygen deprivation of these tissues, which is called infarction of the downstream tissue. Whereas embolization in the pulmonary circulation leads to congestion, hypoxia, and it can cause right-sided heart failure. So this is what I meant by depends on the site of origin. So if the embolus is within the systemic circulation, we believe that it may result mostly in ischemic necrosis or infarction. But if the embolus is primarily within the pulmonary circulation, this means that it will result in hypoxia, maybe pulmonary hypertension sometimes, and right-sided heart failure. As we said in the last slide, we have systemic thromboembolism and pulmonary thromboembolism, depending on its site of origin. So now let's start with the pulmonary thromboembolism. Almost all large pulmonary artery thrombi are embolic in origin, and in more than 95% of cases, venous emboli originate from thrombus within the deep leg veins, proximal to the popliteal fossa, most often the popliteal vein and the large veins above it. Let's now talk about the major clinical and pathologic features of the pulmonary thromboembolism. First, the majority of pulmonary emboli, which is around 60 to 80%, are considered small in size. What does that mean? This means that they are asymptomatic or clinically silent, associated with no symptoms. With time, they undergo organization. Remember when I said organization and incorporation within the vascular lumen? Yes, those small emboli will undergo organization and become incorporated within the vascular wall. On the other hand, large embolus may block a major pulmonary artery or one of its main branches, resulting in sudden death. Remember the sudden embolus that we talked about when we have a thrombus that is at the bifurcation of the right and left pulmonary arteries. This is called sudden embolus and it will result in sudden death. Embolic obstruction of medium-sized arteries, pulmonary arteries I mean, results in rupture of downstream capillaries and this will result in pulmonary hemorrhage. So, the majority of pulmonary thromboembolism are silent or asymptomatic, and this is about 60 to 80%. Large one, which is not common scenario, may result in sudden death. Medium-sized ones that will cause obstruction to medium-sized arteries will result in pulmonary hemorrhage. Why pulmonary hemorrhage? Because there will be a rupture in the downstream capillaries. Such emboli do not usually cause pulmonary infarction, I mean the medium-sized artery embolus. This is because the area receives the blood through the intact bronchial circulation. Remember the dual blood supply to the lung? The lung receives the blood from the pulmonary arteries and also from the bronchial circulation. So the medium-sized arteries, even if there is an embolus obstructing the vascular lumen, they still receive the blood supply by the bronchial circulation. So that's why they do not have ischemic necrosis or infarction. Instead, they undergo pulmonary hemorrhage because of the rupture of downstream capillaries. So the pulmonary thromboembolism, as we said, about 60 to 80% are silent, asymptomatic. And if we have a large embolus, and this is not a common scenario, it will be dislodged at the bifurcation of the right and left pulmonary arteries or even occluding one of the main pulmonary arteries. This may result in sudden death. If we have a medium-sized embolus obstructing a medium-sized artery, this will not result in infarction because of the dual circulation, because the tissue still receives the oxygen by the bronchial circulation, even if the pulmonary circulation is obstructed. But instead, it will result in capillary rupture and pulmonary hemorrhage. Embolism to small end arteriolar pulmonary branches usually causes infarction. Why? Because this tissue have limited blood supply. So the more distally located the embolus, the less blood supply, and so the more risk for infarction. So usually infarcts happen at the periphery of the lung. Multiple emboli over time may result in pulmonary hypertension and right ventricular or right side heart failure, which we call it cor pulmonale. This figure shows the macroscopic or gross appearance of an embolus, which is large here, and it's derived from the lower extremity deep venous thrombus and lodged at the pulmonary artery branch. This large thrombus may result in sudden death, and as I told you, the majority of pulmonary thromboembolism, they are silent, about 60 to 80%, they are asymptomatic. Only 5% may result in sudden death if they cause obstruction of one of the main pulmonary arteries or if they are dislodged at the bifurcation of the pulmonary arteries. So let's remind you the pulmonary thromboembolism. We say that the majority of the pulmonary thromboembolism, they arise from the deep veins of the lower legs, mainly around the popliteal fossa, right? And the embolization site is mainly within the pulmonary circulation, right? Let's compare that with the systemic thromboembolism. So the origin of the systemic thromboembolism, most commonly, they arise from the intracardiac mural thrombus. Intracardiac mural thrombi are mostly caused by left ventricular infarcts and dilated left atria, like in cases of mitral valve disease. Other less common origins include aortic aneurysms, thrombi overlying the ulcerated atherosclerotic plaques, or venous system emboli. About 10 to 15% of systemic emboli are of unknown origin. So please always remember that the most common origin of the systemic emboli, which is about 80% of systemic emboli, arise from intracardiac mural thrombi, and this is mostly due to left ventricular infarcts or dilated left atrium. So, as we said, the pulmonary emboli are usually venous or most commonly venous in origin, arising from the large deep veins of the legs, and usually they lodge in the lung, right? While the arterial emboli can travel anywhere in the circulation, and their final place depends on their point of origin and the flow rates of the blood into the downstream tissues. The common arteriolar embolization sites include first, lower extremities. So, here in the systemic emboli, the lower extremities are the most common embolization site, accounting for 75%. Also, the central nervous system accounts for 10%. Intestine, kidneys, spleen are considered less common targets. Let's remind you with the definition of embolism. As I said, embolism is an intravascular, solid, liquid, or even gaseous mass that is carried with the blood from the site of origin to another distant site, resulting in tissue dysfunction or infarction. So, the embolus can be solid, as we discussed in the previous emboli, the thromboembolism, but it can be also liquid or gaseous. So now we will talk about other types of emboli. Let's start with the fat embolism. Fat embolism is usually occur after soft tissue crush injury or rupture of the neurovascular sinusoids in patients who have long bone fracture. This would result in release of microscopic fat globules into the circulation. And this is usually the scenario in patients with long bone fracture or severe skeletal injuries. So the embolus is made of microscopic fat globules that travel from the site of the fracture through the circulation. Another type of embolism is the amniotic fluid embolism, and it's uncommon complication of labor, للحمل, due to the entry of the amniotic fluid and its content into the maternal circulation. This happens نتيجة وجود جرح أو tear in the placental membranes and or the uterine vein rupture. إذا خلال الحمل بدخل جزء من السوائل أو الأنسجة المحيطة بالجنين للcirculation of the mother, and this happens due to the presence of site of rupture in the uterine veins أو يكون في عنا شق أو tear in the placental membranes, and this will result of movement of this amniotic fluid and its content in the circulation, resulting in tissue dysfunction or infarction. So, as you all know by now, the embolus can be made of solid, liquid, or even gaseous mass that move from the site of origin to distant sites in the body, resulting in tissue dysfunction and ischemia. So, air embolism is an example of the gaseous embolism. So, here we have gas bubbles within the circulation that are able to obstruct the vascular flow, resulting in distal ischemic injury. The most common example of air embolism is iatrogenic air embolism. This happens during major surgeries such as the cardiac bypass surgeries or during the surgeries the neurosurgical procedures or the brain surgeries. What happens? There will be an entry of small volumes of air into the coronary artery, for example, which is the blood supply to the heart during the cardiac bypass surgery, or entry of the small volumes of air into the cerebral arterial circulation, which is the blood supply to the brain during neurosurgical procedures.